Thank you very much for inviting me to join you. I wish I could have been there with you in Delhi in India today, but at least here from Mexico via video, and we're very pleased to be able to participate in this incredible seminar organized by RTI, by my dear friend Sunita Krishnan, our dear colleague, and in collaboration with the Public Health Foundation of India, our incredible colleague and leader, Dr. Srinath Reddy, and we're just very pleased as the Harvard Global Equity Initiative to be co-organizing this seminar and look forward so much to all of the participation through our representative today with you, Dr. Ahsan Badilia. I'll share with you some of our work specifically around the cancer divide, the equity aspects, and then move through toward some explanations and discussion of what we've done in Mexico. I'd like to therefore start with a little bit of where my own advocacy came from, the personal anecdote, the personal story, and then move into more of the evidence. This is a painting very important to our family. It was painted by our daughter Hannah when she was 11 in 2007, and Hannah painted the health that she saw of her mother, which emanated in that moment from my hair. You can see the life, the fruit, and the flowers coming out decidedly from my hair. Yet, only a very few months later, in my first baseline mammogram at age 41, in a small clinic in the city I call home, Cuernavaca, Morelos, Mexico, I was diagnosed completely unexpectedly with no precedent, no family history of this, with an invasive case of breast cancer. I was treated primarily in Mexico with great help and support from the Seattle Cancer Care Alliance, and I think as a result of that successful detection and access to treatment, I'm with you here today. Yet the road was long. You see me there at a moment of crisis, a moment of reflection, the most difficult moment with the chemotherapy, with our other daughter, Mariana, then only 3 years of age. The process, as it was long, it was a journey, as I think happens with many young premenopausal women diagnosed with this disease. It was a process of many surgeries, 10 to be exact, and a mastectomy, a process of 60 rounds of chemotherapy, as you see there in the upper left-hand side picture, with the oblique background, the dark background, but that small child, Mariana, laughing at the way her mother had to cover her head with old-fashioned head-type nets. My husband, Julio Frank, who lived this disease with me. You see us as a couple in the chemotherapy ward bed together, understanding the disease. And he, having at that point in 2007 just completed 6 years as Secretary of Health in Mexico, would say he had learned about health systems, he had led a health system, but in this case, we lived a health system. And that, with a chronic, non-communicable disease like breast cancer, teaches you a whole new way of understanding the challenges that patients face as they try to navigate complex diseases over long periods of time. We set up a small NGO, created a small NGO, Tómatelo Pecho. It means literally take it seriously, or the Spanish translation specifically is take it to breast. We've written this up as a book. In Spanish, Tómatelo Pecho. In English, with Harvard University Press, is Beauty Without the Breast. That global task force has an unusual diagonal approach. I'll tell you more about that in a few minutes, what the diagonal approach is. But what was diagonal about this task force is the combination of experts in global health and health systems with leaders in cancer care, and generating a space for conversation between the two that had never existed in the past. That produced a couple of Lancet papers, and the book that I just showed you, Closing the Cancer Divide. And what Closing the Cancer Divide does is to apply a diagonal approach, which is a combination of the vertical disease-specific and the horizontal systemic approach to health system strengthening, to be able to break down those false dilemmas that we've created around the so-called communicable or non-communicable diseases, and that continue to plague global health. The book itself talks about what should, could, and can be done. The last 5 chapters of the book are dedicated to ways to close the cancer divide as an equity imperative. And the book is organized around breaking down 4 myths that cancer in low and middle income countries is unnecessary because it's not a major health issue, is unaffordable, is inappropriate to do because it takes away resources from other diseases, or it's impossible to undertake. In fact, there's a double burden for health systems, just like in the case of the epidemiologic transition. Low and middle income countries increasingly face both infection-associated cancers and all other cancers. More than 90% of cervical cancer cases and more than 95% of deaths today happen in low and middle income countries. Both diseases are in fact leading killers, particularly of young women. That tells you about levels, but we went into the equity aspects to show that cancer is a disease of both rich and poor, yet it is increasingly the poor who suffer along 5 different axes. The opportunity to survive, our honorary president of our task force, Princess Dina Mired, said, should not be defined by income, yet as you can see in these graphs it is. What you're seeing on your left-hand side are children, on your right-hand side, adults. These are all treatable cancers. Countries are lined up from low income to high income. All of these graphs are downward sloping, meaning that the probability of dying is much higher if you're diagnosed in a low-income than a high-income country. We could argue about the slope of these graphs, but we cannot argue that they are all downward sloping. And look at the statistic for acute lymphoblastic leukemia in children. Now let's look at what we call the most insidious injustice, the pain divide. In these maps that show population, no, they show access in this case. Access to morphine or opioid equivalents per death in pain from HIV or cancer. The United States and Canada blow up an average of approximately 350,000 milligrams per death in pain. Mexico at a low of 3,500. Africa virtually disappears. India becomes a tiny little line in this graph with a level of consumption of only 467 milligrams per death in pain. Well, in fact, we say that what's not affordable is not to act. The costs of inaction are huge. We must invest in action. The case of tobacco, well known, costs the world 3 to 6% of GDP per year. The total economic cost of treating cancer is 2 to 4% of global GDP. But let's compare that with the opportunity cost of lost lives. 1/3 to 1/2 of cancer deaths are avoidable. That's 2.4 to 3.7 million lives per year, 80% of which are in low and middle income countries. Comparing the economic value of those lives, just the economic value, compared to the cost of a basic package of prevention and treatment, shows how the world could save every year between $130 and $940 billion by investing appropriately in cancer care and control. And furthermore, the costs to close the cancer divide are typically less than many fear. Our oncologists group for the Global Task Force showed that all but 3 of the 29 most important priority cancer drugs were off patent. We saw that pain medication is extremely cheap. And we've seen around the world and over time that prices can drop with appropriate financing mechanisms. Take the case of the hepatitis B vaccine and now the HPV vaccine for cervical cancer and neck cancers and others. We know that with appropriate delivery and financing platforms, like Gavi, for example, prices can drop, and that's what we have to strive towards in making cancer care and control affordable in low and middle income countries. That's the diagonal approach. The essence of the diagonal approach is that rather than focusing on either disease-specific vertical interventions or horizontal systemic programs, we look for interventions that do both. Interventions where the outcome is more than the sum of the parts. Here are a few examples. I'll focus on 2. Promoting prevention and healthy lifestyles helps with cancer and with many other diseases. Reducing stigma around women's cancers contributes to reducing gender discrimination overall, but it also helps us with dealing with cancers like breast cancer. 2 examples of how you diagonalize. In financing, integrating cancer care and control into national health and social security programs, and on delivering, harnessing programs around maternal and child health, but also anti-poverty programs, HIV/AIDS programs, to be able to integrate effective policies, and awareness-building projects for earlier detection of our cancers. Mexico's Seguro Popular was a major reform that came in place in 2003. It was designed by my husband, by Julio Frank, working for President Vicente Fox. It's a diagonal strategy that works on covering from poor to rich, but also increasing the size of the package. We've seen huge increases in affiliation, from 6.5 million in 2004 to over 55 million in 2013. And the size of the benefit package has increased continually and substantially. One way of seeing how the package has increased is to look at the coverage of cancer interventions through our National Catastrophic Illness Fund. This is an accelerated universal vertical package. And we can see over time how the number of cancers that are covered fully has been increased as the funding available for the catastrophic fund has grown. Our statistics are lacking because we do not have a cancer registry, but I'll give you two pieces of information that I think show how much this program is meant for cancer. In our National Cancer Institute, in 2005, they saw 600 cases of breast cancer, but 200 dropped out, a third, because of lack of money to pay for treatment. By 2010, with Seguro Popular, 900 cases and only 10 had dropped out. But let's meet Don Guillermina Avila. I met her in a chemotherapy ward in Guadalajara, Jalisco. And Don Guillermina had recurred. Bad news for any cancer patient, any breast cancer patient, just like any other. Yet she had this huge smile and she said to me, you know, the first time around I bankrupted my children, they had to sell their businesses to pay for my care. Now, my care is completely covered through the Seguro Popular, and for that I'm proud and grateful. That's the human face of the Seguro Popular. We know that we have a delivery failure. We know that breast cancer is the #2 killer of women in Mexico, women aged 30 to 54. It's number 3 or 4 across the country. And we also know that late detection is a huge problem and that it mirrors poverty. Mexico basically goes from rich to poor when you look from north to south, and you see a huge exponential increase in the probability of late detection of breast cancer as you move into the poor of the south or the poorest municipalities in our country. And our question was what to do about that. And that's where we look to diagonalizing delivery interventions to deal with this delivery failure. Here's the first example. We took our anti-poverty program, Oportunidades, that pushes forward an anti-poverty program for almost all of the families who live in poverty in the country, led through and by the women who head those households. By including information on breast cancer early detection, which had not been there before, we literally in a month and with almost no investment reached out to 1.5 million promoters and over 90% of poor Mexican households, 5.8 million families. But we realized that this was not enough. Getting information to women, awareness building, is not the same as actually getting them care. And then we were tremendously deficient in terms of the knowledge base that our primary care physicians, nurses, and community promoters had at their disposal to be able to deal with this disease. So we co-developed and co-implemented with our partners at the National Institute of Public Health of Mexico a major set of tools to train all of these groups, from physicians to nurses, medical and nursing students, and professional and community promoters, using train the trainer and mixed methods, in print, online, in person, and interactive methods, to be able to train first in several states at the level of a few hundred at a time, and most recently in 2014, through our Mexican Social Security Institute, we managed to go to scale and train this past year almost 10,000 physicians and nurses. We undertook rigorous evaluation, and we offered officially recognized diplomas for those who passed. And that rigorous evaluation has been extremely important. You see some of the results graphically here for the case of community and professional promoters from the states of Jalisco y Nuevo Leon. We did pre, we did post, and we did follow-up evaluation. And we were able to demonstrate that competency-based train-the-trainer models generated not only knowledge, but knowledge that stuck with the promoters over time. And we concluded that health promoters constitute a huge force to be able to meet the challenge, in this case of breast cancer, and I would say the challenge of many cancers and chronic diseases. We, and I say we with my colleague who led this publication, Dr. Nancy Keating from the Harvard Medical School, we published these results very recently in The Oncologist, and soon we'll be publishing the results that we have going to scale with the Mexican Social Security Institute. I conclude with this slide. I showed you a series of delivery interventions that would basically work in the resource generation category. And I showed you a financing intervention, which is the Seguro Popular. But now I want to complicate the whole picture of how you respond at the systemic level to a disease like breast cancer, but in fact to any chronic illness, be it communicable in origin or not. We've undertaken this analysis for HIV/AIDS as well as for cancers. And what we believe is the complexity of dealing with a disease like this, with systems that were designed for episodic care, is to begin to think across all health system functions, stewardship, financing, delivery, and resource generation, that means human resource capacities and evidence, but also across each of the 6 stages of chronic diseases, from primary prevention, secondary prevention, early detection, diagnosis, treatment, survivorship, and palliative care and end-of-life care and control of pain. What happens if you offer treatment without early detection? You end up over-investing, very costly treatment, late-stage detection. What happens if you only undertake prevention or early detection with no treatment? Your patients won't survive as they should. It's not enough to just prevent. We need an integrated whole, and when we think about health system efficiency, we need to think in this way and think diagonally. So I want to take this opportunity now to thank you again for inviting me, to congratulate RTI and Sunita on now leading the charge in India with the post heading RTI in India.